Thank you so much, Christian. Thank you. So we've made it to our last session. Well done, everybody. I'd like to welcome Richard Webber, consultant physiotherapist from STH, to come and talk to us about fibromyalgia, please.
This one, lovely. I feel like they put fibromyalgia at the end to give you that sort of feel of it, end of the day. Oh, fibromyalgia, perfect. So hello, I'm Richard Webber. I'm a physiotherapist who works for Sheffield Teaching Hospital. Which one? Just that one. I get the fancy title of consultant because half of my job is part of the senior leadership team across all of the trusts for MSK therapy, but the other half of my time is as an advanced practice physiotherapist in PhysioWorks. All the patients I see have persistent pain. A large proportion of them have widespread persistent pain. I usually explain to patients that my role sits somewhere between physiotherapy, orthopaedics and rheumatology. I see patients where it's perhaps unclear what's going on, and we're considering, do we need to think about further investigations or different diagnosis or referral to other services. I'm going to talk from my personal perspective of doing fibromyalgia diagnosis and what I've found over the years works for me and why. However, I'm aware I get 60 minutes for a new patient and 45 for a new one, 30 for a follow-up, and you certainly don't. So what I've done is divided up what I would normally do within one session into 3 chunks, which you could possibly then work around how you do it. But I'm happy for you to take whatever you like from this talk and use it in any way that's helpful to you. So, where am I pointing it? So I'm going to talk very briefly about fibromyalgia and evidence around it. I'm going to focus more on the practicalities of the diagnostic process and then also talk around the management of it, what you can do and what else is out there.
Do you think you could put your microphone a bit? I don't know if it's not working or if you need it a bit nearer your face.
Okay.
Yeah.
Is that better?
Yeah, right in front of it.
I'll keep reminding me because I don't usually use one of these. So okay. So fibromyalgia is a syndrome. So it's a collection of symptoms that are commonly seen together, but we don't actually have a clear etiology about them. We know that it's to do with dysregulation of the pain system at multiple levels. There's growing evidence that chronic low-grade inflammation is involved. Various different hormones are involved. They talk about the gut biome, processing at the spinal cord, processing in the brain. And also more recent research that's come out of long COVID around whether mitochondrial dysfunction might be contributing to the fatigue aspect of some of the symptoms that they get. I think for me, what that tells us is that this is not a purely psychological disorder. It's more complicated than that. There's more going on. And also I think it's important to think about that pain system as being throughout the body and not just talking about being pain. The worst thing is people think you're saying, so this is all in my head. And pain is not all in your head, it's in all of your body. So it's thinking about this in that way. Under the ICD classification of diseases, it comes under the category of primary pain, persistent primary pain. It's a subcategory of that. If you're really interested in the science and stuff, I'd recommend these yearly reviews that come out and just give you an update of where they're at on all those various things. So it's usually it's quite short, but well written. As I'm sure you're aware, fibromyalgia is associated with lots of other conditions that you commonly see at the same time. And something that makes you think that perhaps there is a relation to inflammatory disease. It is actually very common in things like rheumatoid arthritis, so they can often have both. Obviously, mental health, weight, blood pressure, cholesterol, neurodiversity, social and economic status, adverse childhood events. When I worked in pain clinic, I would say at least half of the people that we saw, something significant had happened in their childhood, and it's probably higher than that. I usually ask people, I don't usually get them to go into detail, but it's sometimes helpful about picking out what it is. I suppose one of the things with this is that I'm really aware of is when I speak to people, I'm just talking about their persistent pain. When they come to see you in your 10 to 15 minutes, they'd like to discuss all of this as well. So I do get that it's difficult, but sometimes focusing in one part might help it move forwards. Ooh, wrong way. So, diagnosis. So the approach that I take follows what is recommended by the Royal College of Physicians. This webpage is excellent about fibromyalgia diagnosis, both for as clinicians but also for patients. They do a really good short handout on fibromyalgia that I give to some patients. One of the things that I think is really important to take away from this is they feel that fibromyalgia diagnosis is something that can be and should be done in primary care, and it does not need referral to specialist services in most cases. But it isn't something that only a pain doctor could diagnose or only a rheumatologist could diagnose. Anyone who can complete all of what's needed can do it. So this is taken from it. So there's 3 parts to their diagnosis process. There's the widespread pain index, there's the symptom severity score, and there's could it be something else question. So there's 3. This is from their website. I just have a Word document that's got all of that on that I cut and paste straight into System 1 Notes and use. I keep thinking I should get a template made by someone to do it, which would be a helpful way of going through it. So before I go into those a bit more detail, I suppose it's sometimes just thinking about it. Not everybody who presents with persistent widespread pain needs to go through all of this process and needs the label of fibromyalgia. And often people worry about giving the diagnosis or give a vague diagnosis of it because they're worried that having that label is going to promote illness behaviour. It's going to shut things down so they don't consider other illnesses, or think, oh, maybe it could be this or it could be that. Perhaps there's a stigma related to it, especially if you're thinking it being a disease in your head. Is it going to damage your healthcare relationship? If you say, I think you might have fibromyalgia. And will it then lead to increasing healthcare seeking behaviour? All of these are possible, but I think if you do it well, you empower the patient, you give them focus about where they're heading to, it reduces down some of that internal uncertainty about, well, what is going on? What's causing this problem? And for a lot of patients, it reduces some of that external uncertainty so that it has something they can tell their work about what they've got, or their family, or any of those other things. They can say, this is what it is. And if you do it really well, you could potentially reduce healthcare seeking behaviour, but I wouldn't give you any guarantees on that. As part of a research fellowship, I did a review of papers related to patients' experience of getting fibromyalgia diagnosis, and I interviewed patients from all over the country about their experiences and what was positive and what worked from them. GPs came out really good from this, to be honest. There was more stories about them being good than there was about rheumatologists or pain doctors often, because what made the difference was when they felt listened to, when they felt someone understood the difficulties that they were going to, and that when someone gave them a different perspective, that gave them some hope that there might be a way forwards of getting out of this. And that's different to helping them. And we might come back to that. I'm sure you all do all this. But it's just a thing to bear in mind that what my conclusion is that diagnosis is an intervention. It's part of the treatment. So doing it well is part of the treatment. You don't diagnose and then treat with fibromyalgia. You start with the diagnosis. So the first one, widespread pain index, and these are pretty much the words that I say to every patient when I'm doing these. So I'm going to give you a list of body parts, and I would just like you to know whether you regularly get pain in that area. Do you get pain in your face and jaw on either side? And then I work on my way through that. It's quite a long list, but actually I would say, it's coming loud again. I would say it can often speed the process up. So sometimes I'd say to some patient, it sounds like you're getting pain in lots of areas. What I'd like to do to make sure we don't miss anything is go through a comprehensive list of body parts and ask you whether you have pain in that area. So if you've got somebody it's difficult to keep on target, actually this helps. If they drift off on target, they start talking more about the pain, I think you can often bring them back with a reflection on. So something like, so it sounds like the pain's worse when you're standing at work. Do you get pain in your hips as well? And then you just move on down through the whole list to work your way through of it. And you can finish with a reflection. It sounds like you've got pain throughout your body. And they'll say, yes, it's everywhere. They get a score out of 19 for that. Second questionnaire is the Fibromyalgia System Severity Score, and this talks about those other commonly associated ones. So I usually say, in addition to your pain, I'd like to ask about some other systems that you might have. Do you suffer with fatigue or tiredness during the day? And then say, would you rate that mild, moderate, or severe? When you wake from sleep, do you feel recovered and refreshed? Would you describe your sleep issues as mild, moderate, or severe? Do you struggle or concentrate to remember things? Would you describe these problems as mild, moderate, or severe? Wording it in that way seems to work quite well. I do quite a few through interpreters, and again, I get reasonably good answers those. Sometimes it drifts off. And then you ask about headaches, and then you ask about depression, and then you ask about stomach problems. Sometimes you know all of that, some of those things already, and you don't necessarily, you might just say, and looking at your notes, or I know that you're also suffering with migraines as well, is that right? Or I see that you're waiting for more investigations of your stomach issues. For that part. I think if you were dividing it into 3 sections, this might be a nice section to say, thank you for that, that's been really helpful. It feels to me like there probably is something that's connecting all these symptoms together. What I'd like to do is some blood tests and then bring you back to discuss, to finish off the examination and discuss what we found and go from there. So it can give you, and I think sometimes if I'm short on time, that blood test gives you that kind of gap. And it gives them, Painkiller like to talk about a therapeutic pause. 6 month therapeutic pause for them quite often. But it sometimes gives people some time to think about what they've been told when they're moving forwards to that next part of it. So if you're going to divide it out, I think that would be a good place to then send it off. You don't have to do blood tests for everyone with fibromyalgia. Often you've sent them to me, they've had quite a lot of these done already. I certainly wouldn't repeat anything that would come back as normal. That first row is my kind of standard ones that I would consider, depending on what they've presented with. I'm guessing there'll be fairly standard ones that you'd send through as well. Obviously, you can have fibromyalgia and you can be anemic. You can have fibromyalgia and be almost highly likely to be type 2 diabetic as well. So identifying those things as well as, or instead of, is important. My wife's a GP, and I put rheumatoid factor on, and then I had a list of other inflammatory tests that I can send for, and she said, don't put that on, you'll get in trouble. Sometimes we consider inflammatory things, and we'll send them for other stuff as well. And that can sometimes be one of those ones where you're thinking, well, is this an inflammatory disorder? And it's certainly talking about. Bence-Jones, older people, multiple myeloma, definitely one to think about. They'll come with some odd symptoms, and you think, maybe. And that's where we come to that third question around other causes. Obviously, you're experts on that part of it, so it's not too difficult. Things that I mostly consider, have they got an inflammatory disorder, neurological disorder, a major MSK structural disorder, multiple myeloma, as we've talked about, hypermobility spectrum disorder, and hypermobile Ehlers-Danlos. That's a whole nother talk. It's not a group that I particularly find it's difficult, easy to manage, but there's a very strong crossover between the two, and I'm sure you'll find that some people who feel that label is more fitting to them don't like to be told they've got fibromyalgia. But my view is, don't look for zebras at Ascot when it's obvious that it's this, which can be difficult because they do present with neurological symptoms, they talk about swelling, they talk about all sorts of things that can definitely throw you off. But I think it's coming back to thinking, but overall I don't think so. And I really think that if you have, I'll go backwards. It won't go backwards. If you've done the good part of that objective testing, which we'll come back to. So, next session, they come back, you say, good news, we've done all those blood tests are fine, I've got a good idea, I think, of what's going on. Before we go further, I'd like to do a thorough assessment of you to be certain about what I'm talking. I don't necessarily do, I think I do most of this actually each time with it, but I do it pretty quickly. So I think if we think back to those other things, I think if you've looked clearly at their hands and feet, you've got a good idea they haven't got a vascular problem. You've got a good idea that they haven't got an inflammatory problem. If you've tested their reflexes, you've done their planters, their Hoffmans, maybe a rhombos to look at their balance, you can be fairly clear that there's not a major neurological thing going on. Again, you look at the hands, vascularly you're fine. Movement-wise, it's pretty quick with mine. Can you reach behind your head? Can you reach behind your back? Can you touch your toes? Can you do a squat? Can you balance on one leg? I've already seen them walk in. I've got all of those things with it. That physical assessment, I think, is essential for that third question, is there anything else going on? But it has a much wider impact on what happens with it. It demonstrates to the patient that you're taking what they're saying very seriously and you're considering all the options. And that contact, when you're touching people and moving people around, is really important to that relationship that you're building up as you build towards talking about what you think's going on and where you go from there. So it's a very important, strong part of it. And that's one of the main complaints that people have. Well, no one touched me. How do they know what's wrong with me? They didn't even touch me. So do it, but you can do it pretty quick. So there is a scoring system for it. I never use this scoring system, I'll admit. Because what you'll find is they're either, well, they definitely are, they're 19 out of 19 or 10 out of 12 for the second one, and everything else is fine with it, or they're pretty much on that other scale. You think, I don't think this is. There are people in the middle, and the people in the middle, what I tend to do is talk more about how their pain system has become sensitized by other things going on, rather than talking about fibromyalgia. So I don't really count up the scores and work it out which goes to which. And actually those scoring systems are probably the most debatable part of the diagnostic process. And when they've looked at it, what they're saying is this sort of pain system sensitivity is dimensional disorder. We're all on that spectrum. We move up and down it. Sometimes it's worse and sometimes it's better. I quite like that because I think it's quite positive, because it shows that at times events in your life can move you up that process, which means if you can identify ways of moving yourself down again, there's opportunities for improvement, rather than saying you either got it or you haven't got it, and once you've got it, there's nothing that could be done. And it's not talking about a cure, it's saying we can move you in different directions. So I sometimes talk about that with patients as well, but to bear that in mind. But most of the people who you think have got fibromyalgia, they'll score really highly on it, and it won't be ambiguous at all. So, I've done all that. I think, oh, okay, this presents as fibromyalgia. So I would usually say to patients, taking into account everything that you've said, the blood test that we've done, and the thorough examination that I've done today, I'm confident that you present with what we call fibromyalgia. Is that a condition that you've heard of? And then I wait to watch and see what their reaction is. Some people just say no. Some people say yes and fold their arms and look quite upset by it. Some people are relieved because their husband, see, I told you it was that. So looking for that, and certainly with all of these things, you know, what I say is based around this, but it will change from person to person. And then I would usually say, if they say, oh yes, I've heard of it, I'd say, what's your understanding of it? What do you think to that as a diagnosis? To get that part before we move on to explaining what's going on. And I would always explain what's going on based on what they've told me, using the words and the experiences they talk about. But I admit to them fibromyalgia is a condition that we don't fully understand, and that normal sensations inside your body are perceived and threatening, and you experience this as pain. And I often explain the feelings of fatigue, poor sleep, and brain fog as being overwhelmed by all of those symptoms that you have. Overwhelmed is a very clear thing that people talk about in fibromyalgia and their symptoms. So saying that your body's overwhelmed by everything that's going on is helpful for them. And then once I've explained it, I would usually say, how does that fit with your experience? And they usually say, well, that's exactly what's going on from that point of view. Sometimes. Again, I think if you're short of time, that might be a nice time for that, one of those therapeutic pauses. So you can say, well, why don't I give you some information to go and have a look at? And then if you want to, you could come back to see me and we could talk about what your plans are for moving forwards. That's my very motivational interviewing approach to saying, we'll see you again. But even just using words like that of, what you want to do next, I think is important. All my slides will be available. There's loads and loads of information about fibromyalgia. I think these three are really good. First is arthritis. It's excellent. It's in more detail. The Fibromyalgia UK is perhaps a bit more patient-focused. And the Royal College of Physicians is a one-side A4 sheet, which for some people I think is perfect for it. So giving them that to go away and think about. Okay, so they've gone away and thought about it. And now we've got the treatment side of it. This is the hard part. So the NICE guidelines for pain came out in 2021. I don't think everyone was very pleased with it. A lot of patient groups weren't pleased with it at all. And really it was a list of things that you can no longer do rather than what you can do. They talk about person-centered assessment, which we've already discussed. We've talked about providing advice, information, non-medical treatment. They talk about exercise, physical activity, and then they talk about psychological treatment such as assessment and ACT. Medication-wise, they say consider an antidepressant. Don't prescribe anything else. If somebody is on something, encourage them to come off of it. I'm going to go straight to medication, and then we'll jump back one. Further to that, the Cochrane did a review of 25 different antidepressants, and the only one that they came out with finding some moderate evidence that it has effect was duloxetine. So if you want to prescribe anything, the recommendation is duloxetine. Starting dose, depending on the patient, you can start lower at 30, or you can start at 60, increasing that as they need to daily. Obviously, it's not a wonder drug. Obviously, there's people out there who don't tolerate it. I feel it probably has less side effects than some of the others, than pregabalin or gabapentin, but who knows. And some people who've tried, say, amitriptyline and didn't like it, do swap to duloxetine and are okay on it. So just because they've not worked on one, you could try the other. But that's it. There's nothing else. And there's nothing else in pain clinic either. So it's not that they've got some other options in terms of medical treatment. So I usually say, unfortunately, we don't have a cure for fibromyalgia. There are medications, but they don't work for everyone, and only partial pain relief, and then beginning to talk about pain management. That's going to be a disappointing answer for them. I get that. And I'd say that to people. You know, I'd say I'd much rather we had a tablet I could give you that would make you better, but we definitely don't. However, there are people out there who change their approach to this illness and find ways forward and improve their lives. And that's what we'll be trying to work with you. So it's about trying to find ways to reduce sensitivity in your pain system, reduce the feelings of being overwhelmed, and re-engage with what matters to you. And then when we've talked about that, straight away into do you have any ideas about what you want to do next? These people are distressed. They really want you to help them. They really want you to fix them. It's a very hard shift towards, because you really want to help them and you really want to fix them. I do as well. But it doesn't work, and you need to be careful that you're moving into a relationship which actually isn't helpful, where you're trying too hard and we're not moving them forwards. Empowerment is not about that. It's about shifting in the other way from it. So it's about giving people control over their health and moving them into their community part of it. An ACT approach can be helpful, so that's thinking about what's important in your life, thinking about how you can get back to doing those sorts of things. I often talk to people about what things do you do that you really enjoy, and they usually say nothing. And if we start with nothing, with anything, we start with, well, what things do you really like doing that we could bring back in as a starting point of doing something? Because they're the things that go out first. So they get rid of the things that they want to do, the things that they like doing, and they just do the things that they think they should do. So bringing them back in. I would say your number one choice of things to do would be to encourage them to engage with some form of social prescribing. Social prescribing is good because it helps them to re-engage with themselves, reconnect with themselves. It helps them to reconnect with the community and people around them, and it's the best way of providing that long-term support that they need. It's not something where you can have 6 weeks of something and now, oh, well, you're okay now, you're going to be fine. It needs to be built into everything that goes on around them. So I would definitely encourage them to go down that route, find out what's local to their area, what works for them, and what fits with their lifestyle, and asking them, what would you want to do? The best thing for them to do is the thing that they suggest to you. Often you think, well, if you want to do that, you can do, and it's not necessarily what you want to do. But it's certainly better than nothing, and it's better than not doing anything at all. And suggesting, why don't you do parkrun, or why don't you do it doesn't work. It pushes them back against it in the other direction of it. So you've got to put it out there for them, but it's going to be down to them about what they want to do. Above that, so PhysioWorks, who I work for, I have a team who specialise more in persistent pain. They see all sorts of other people as well, but they've got more training in that. They've all been trained in motivational interviewing. We've all had some ACT training. They're very good at working with patients, exploring their thoughts and feelings and behaviours, and seeing, can we identify things that you are avoiding doing or not doing, which is making things worse rather than better. There is a difference between seeing somebody and being given a standard sheet of exercises, and seeing somebody who takes their time to look at how you move and what you do and what you think, and identify what's going on. So even people who've had physio before, it may still be an option if you think that's part of it. So somebody who if I see somebody and ask them to touch the toes, and they grab their hand like this and they move like that, I think, right, we're in here. We've got some things we can work with and change. We have a Roma pain group, so that's specifically people from the Slovak Roma community. I'm not quite sure why there's such a high proportion of people with fibromyalgia symptoms in that community. I'm sure it's something is social economic, but I do see people from that community who speak really good English, have a job, and still have those symptoms. So I'm not sure why, but there is a high proportion of them have it. As I'm sure you're aware, they can be slightly a difficult group to engage with, to get them to turn up. We still have low, high DNA rates, those sorts of things, but we work with them. But it's been amazingly positive. And actually what they don't say is, I want more tablets. They want to do stuff. They want to exercise. They want to move. They want to go and do activities. I wish I should have brought some pictures. We've got some great pictures from that group. It works really well. If you wanted to send someone through, if you send that through through the MSK normal form and say, oh, I wonder if they'd be suitable for the Roma pain group, we'll just look at that and put them in as we need to. We usually send face-to-face first, but then go from there. We also recently started a non-English speaking group. This is more to do with persistent back pain rather than fibromyalgia, which equally is working very well. We have a reboot exercise group, so some of the patients we put into a group which is just about getting them to move in a way where they start to realise that it's okay to move and be in pain. It doesn't cause me harm or damage. Maybe I can do more. We're limited in our resources. They will be seen perhaps 3 or 4 times maximum over a period of time. So it's not everything, but for some it could be helpful. So if you feel like they're not ready to engage with social prescribing, you want something to get them to that level, I think that's where we're helpful to it. My role in all of that is diagnosis, sending some people for investigations, some people on with referrals to pain clinic or rheumatology or orthopedics, but also often patients who have fibromyalgia, but you also have a frozen shoulder. You've got fibromyalgia, you also got a problem with the knee, you've got sciatica. They often get sent to me because it can be difficult to pull out which one's doing which and working with it. And I'm perhaps a bit more sensitive to their needs and working through it. But I'd always be happy to see them and work through them with that. Alternative options. They'll ask you about lots of these sorts of things, and lots of these things work really well. Acupuncture is actually in those pain guidelines, but it's not funded by the ICB in Sheffield, so we don't have any access to it at the moment. it was one of those things that worked quite well for some people and didn't work well for other people. But if a patient's talking about it and saying they're wanting to self-fund for it, I certainly wouldn't say, oh, it doesn't work. I'd say, yeah, that's something that could work for some people. It's worth trying and seeing what impact it has, as long as if it does improve it, that you then look at other ways of activating yourself. Massage fits in the same category of it, and any sort of manual therapy, whether that's chiropractors or osteopaths, there is some evidence to support it being helpful. But I think, again, in a short-term pain management way rather than the long-term way, and we're certainly never going to get to the stage where everyone with fibromyalgia gets a massage every week. Hydrotherapy is another good choice. Ever since COVID, they've never let us back in the pools so we don't have access to the hydrotherapy pools at the hospitals at the moment. We're trying to get back in, but they've got waiting lists, and they say that we're just going to get in the way of that. If you've got any patients who live north towards Stocksbridge, I would highly recommend the Soak and Socialise. So this is at Stocksbridge Leisure Centre. They've got a hydrotherapy pool. They come in, they do some exercises together. There is someone who is a psychological wellness practitioner who then meets with them afterwards and talks about pain. It's price-wise, it's pretty low. They can go regularly. Anyone who I say Stocksbridge, I think, oh, I've got something great for you, and I get good feedback about it. The only problem is it's in Stocksbridge, so it's not handy for everyone else. Obviously, then people ask me about lots of other things. These are the two that I just came up with this week of people asking me about various different things. Usually, I kind of quite open, and I would say if somebody's doing something that's working for them, then carry on. If they're saying, well, somebody said I should try this, I would usually say, I'll find out a bit more for you and let you know. So one wanted to know about traction, no evidence for it whatsoever. And one wanted to know about laser therapy, no evidence for it whatsoever. But I have those conversations about different things that people suggest. Last on your... Oh, I was doing quite well. Oh, gone too far now. Pain clinic. So pain clinic, that's that top level of services that's available. They've got an MDT approach, so there's anaesthetists, specialist nurses, physios, OTs, psychiatrists, psychologists. They've got a big team. There's lots that they can offer. Patients who get seen there, they will get a more comprehensive assessment. So they get an hour, they go through a lot of things. If they feel, as we've talked about, childhood traumas related to it, they might get time with the psychologist, or if it's more than that, they've got time with the psychiatrist. The OTs are very psychological therapy based, so again, they're very good at looking at all those sorts of things. Their pain management program is much more extensive, so it goes on for 8 weeks, and each time they go for half a day. Again, it's not just an education. It's a therapeutic experience when they get together, and it's run at Graves, and I can tell which week it's on. So you can tell when it's week 1, and you can tell when it's week 8, because there's a very different vibe in the room when they're having their tea and coffee. So they do get good results with it. Obviously, people have got to be ready to engage and work with it, but it works well. They can give medication advice, but they don't have any other drugs. They are very good at de-prescribing. There's a specialist nurse who works there, works with de-prescribing. So if that's something that you're struggling with, they would be certainly happy to see. And they would certainly be happy if you were saying, you know, this patient's got these various drugs, I don't know where to go. They'll see them, but it's just to bear in mind, they don't have anything extra particularly, certainly for this group of patients. And as you all know, they've got a pretty long waiting list at the moment. They were Doncaster Pain Clinic decided overnight to stop accepting patients and told them all to go to Sheffield. And so they had this sudden massive influx. This was a while ago, but they've obviously then had to recover for that. So one of the main reasons that the pain clinic has got such a big waiting list is because they're recovering from taking this. They didn't tell Sheffield they were doing this, they just did it. They're recovering from a big influx. I think their waiting list at the moment is about 6 months, which is not ideal. They're working at trying to bring it down, but I think you need to take that into account. And when you're thinking about sending it to there, really you're thinking about those complex patients where you're certain that they really need that more specialist support to work with that. Thank you very much.